Good evening, everyone. My name is Jamie Landman, and welcome to the 5th annual Dr. Wadi Najm UCI Men's Health Day. As you're all aware, this world looks very different today thanks to the COVID-19 pandemic. And sadly, the Men's Health event is not going to include all the wonderful camaraderie we've enjoyed in the prior 4 meetings. Additionally, for those of you who are here in Orange County, you're aware that there's a series of wildfires and tens of thousands of our friends and colleagues have been displaced. Our hearts and prayers go out to them, and our best to the first responders who I'm sure will control these fires in the near future. Despite these challenges, here we are, and tonight we have a virtual seminar, and we are currently in the Dr. Phoebus Landman conference room, where a small group of us are doing a COVID-safe version of this event. Most of our speakers will be presenting from the safety of their own home. I want to start off by thanking all of those who really contributed strongly to the Dr. Phoebus Landman conference room effort. Thank you so much for making this possible. Also, thank you to Dean Stamos for facilitating the process and for so supporting our men's health initiatives. We also want to thank Mrs. Liz Najm, who of course has always been so supportive of all of these events. She's supported us in so many ways. This evening, many of the gifts you've received are from her, and our team will be distributing some wonderful gift baskets to the winner of our raffle. Thank you, Liz. Thanks to you and your family for all your support. And a special shout out to Dr. Wadi Najm's mother, who's now 99.5 years old. Also, we really want to thank all of those of you who have trusted your care to us in UCI Urology. We are so very grateful. Thanks to you, a wonderful team of nurses, technicians, administrators, and our wonderful physicians, UCI Urology is now the number 24 U.S. News and World Report department in the entire country. So out of 1,500 departments, we're number 24, putting us in the top 0.1%. We want to thank you and tell you how grateful we are that our teaching, our research, and our education efforts, as well as the wonderful clinical care that we've provided, have given us this great honor. And we truly pledge to continue these efforts and get even better over the next couple of years. As you know, our department has continued to grow and flourish. I think it was just a couple of years ago that we introduced the concept of an office in Newport Beach. About 2 years ago, we opened up our Birch Street office. At that time, we obviously had 0 patients. We are now serving over 1,000 patients per month from Orange County and beyond at this facility. And the great success of this facility is due to a number of factors. We offer services that literally are only available at UCI, nowhere else in Orange County. We also have one of the best teams. We have amazing nurses, technicians, a beautiful physical plant, and of course, outstanding faculty that really makes this all work beautifully. With that being said, I want to introduce one of those faculty, Dr. Ronald Solomon. He's my friend, colleague, and partner. Dr. Solomon has worked with our team to craft a new vision for men's health. So what we all know as healthcare is truly reactive sick care. We come to the doctor when we get sick. Dr. Solomon and our team want to start focusing on prevention, and we're working on just such a plan. Ron?
Thank you, Dr. Landman. After 32 years in private practice at Hope Hospital, it was a breath of fresh air to return to academia at UCI Medical Center. The philosophy of UCI is to teach, focus, research, and create innovative ideas to advance patient care, just like the Comprehensive Men's Health Institute. Men's health has been neglected for far too long. The vision for this program is emphasis on prevention to improve the lives of all our male patients. For years, the UCI Department of Urology has been a leading referral center for the treatment of prostate cancer. Dr. Tom Allery pioneered the development and refinement of robotic prostatectomy. The program expanded to include talented, innovative, and diverse prostate cancer experts. I have the utmost respect and confidence in these amazing colleagues. I'm excited about our plan to create an elite prostate cancer center for them and the patients they treat. The cancer center will focus on prevention, diagnosis, treatment, and research. The project will be a significant part of our comprehensive men's health initiative. We need to make sure this vision comes true, Dr. Landman.
Thank you, Ron. So as you know, and what we want to share is that, as usual, we want to take it to the next level. This men's health effort will be a center for prevention, and we're calling it the Men's Health Hub that will have 3 Ps at its core. The first one is place. We want to have a unique venue where men can come out not only when they're sick, but to learn and get preventative care. Additionally, we want to give personalized integrative care so that each man gets exactly what he needs when he needs it. And finally, we want to launch a world-class prostate cancer center. As you all know, UCI already provides amazing world-class care in prostate cancer. We have extraordinary expertise in our Department of Urology. Here we are rapidly expediting a plan that will leverage the UCI Chow Family Comprehensive Cancer Center, existing resources in our department, colleagues in radiology, oncology, and radiation oncology, and recruitment of some new faculty, some of the best people in the world, to create a center that's utterly unique where men can come to get what we believe will be the best prostate cancer care in the entire world. Special thank you to Dean Michael Stamos and our CEO, Mr. Chad Lefteris, who've done an amazing job supporting and helping us organize this plan. At this point, I want to take a brief moment to introduce some special people, Mr. Matt Spencer and Mr. Tim Prowitz. Matt and Tim are our development officers. The development team here with us today have done a wonderful job organizing this event, and they will reach out to many of you to see if you're interested in helping us support this initiative. If at the end of this event you're interested, we'll also provide you their contact information so that you can reach out to us as well. So we're going to focus on prostate cancer since this is one of our hot topics of the day. Prostate cancer is a major problem for the men of Orange County and beyond. It is the #1 cancer in men. And to launch the evening, we of course are going to start talking about prevention, one of our priorities. We're very fortunate to have Dr. Pengujang, and he's going to be introduced by Dr. Faisal Yafi, who is of course our very distinguished Men's Health Director as well as a close friend. Dr. Yafi, please come join us.
Thank you, Dr. Landman. Thank you, Dr. Solomon. I'm so excited to be here for the 5th annual Wadi Najm Men's Health Day. The Men's Health Day started when I first came here to UCI, and it's been expanding ever since. It's really unfortunate that this year we have to do it virtually, but I'm so glad that we're able to connect with old friends and new friends. And for all of those of you who are here, I'm sure you remember the quality programs that we've done in the past, and hopefully this year's program is equally good as in the past. With no further ado, I'm going to present our first speaker. So our first speaker is actually a little bit different from usual. In the past, all our speakers were attendings or professors within the department, and this year we have something a little bit different. Dr. Pengujang is actually one of our fellows, and the reason we wanted Dr. Jang to speak is basically a testament to the training that we offer here at UCI. Dr. Jang completed his residency in urology at the University of California, Irvine here with us, and is currently in his 2nd year of fellowship in minimally invasive endourology with Dr. Landman and Dr. Klayman. He is very well published. He's presented at national and international meetings, and he is definitely a future star in the field of urology. And on that note, I'll leave it to Dr. Jang to give us a talk on prostate cancer prevention.
Thank you, Dr. Yafi. Really appreciate that introduction. I hope everyone's staying safe. We can go ahead and move forward to slides. Okay, perfect. So prostate cancer, just to get right off into it, is, there's multiple different factors. There's age, race, ethnicity, genetics, the diet, lifestyle, and also even medications and supplements. So we'll break that off into 2 groups. So if we go next. Next slide. So the first 3, unfortunately, those are the cards you're dealt. Those things you really can't change. The next. However, the bottom 3 are ones that are modifiable. What you eat, how you live your life, and different medications potentially are things that you can actually do on your own to really reduce your risk of prostate cancer. Next. So starting off with diet. One of the most important things is to reduce fat intake, specifically reducing trans fat and saturated fats. Healthy fats are fats that are, on the positive side, include omega-3 fatty acids, and those are present in nuts, seeds, and fish. Next, okay. Trying to really fresh fruits and vegetables is extremely important. Specifically, beta carotene are different substances that are in certain fruits, veggies. Also, lycopene is an interesting story. Essentially, this how it started was there was a lower incidence of prostate cancer in men who had eaten foods with tomato sauce, and that's sort of what sparked it. And further studies have come across that too, so that these antioxidants can be important in prevention of prostate cancer. And then cruciferous vegetables, as you can see here on the right, with all the different types of vegetables, are really quite beneficial and can also have antioxidants and potential substances that prevent prostate cancer. Next. Other things include green tea. Green tea has catechin, and the next word, which we're just going to simplify as EGCG, and also another one is called epicatechin, which are basically phytochemicals. And again, these have shown in lab and animal studies to potentially slow the growth of prostate cancer. And again, these green tea catechins specifically can lower the risk of prostate cancer. Next. Soy is another beneficial dietary kind of choice. Essentially, it includes isoflavonoids, which have been shown to hinder the growth of prostate cancer cells. Overall, has also shown a risk of essentially prostate cancer in men who have basically consumed regular soy products. Next. And it's really important to avoid charred meats and overcooked meats, because when you char the meats, essentially you're producing a lot of carcinogens. So those include these heterocyclic amines and also polycyclic aromatic hydrocarbons. But basically the bottom line is all these charred meats essentially will have carcinogens. Next. Exercise is extremely important, and to really, for patients who are obese, to really get onto a weight loss regimen, because obesity is a risk factor for developing more aggressive prostate cancer. Regular exercise, as you can imagine, besides the other variable health benefits, it overall reduces inflammation, improves your immune function, and also improves metabolism. Next. Smoking, obviously, with itself carries carcinogens, and you'll see people walking around with their masks pulled down and potentially still smoking. So that's not so good. Even if you quit smoking earlier, even if you were a smoker and you quit smoking, your risk of health risks drop dramatically. Red wine in moderation has been shown, however, to have some antioxidant properties. So moderation in that sense would be good, and that'll keep Dr. Landman happy. Next. Vitamin D, or essentially what we kind of like to call sunshine therapy for patients, really is beneficial. It's also been, some studies have been shown to be protective against prostate cancer. Next. And interestingly, staying sexually active has been shown to be a prostate cancer prevention. Specifically, there was a study that looked at men who essentially had higher frequency of ejaculation, were up to 2/3 less likely to be diagnosed with prostate cancer. And the theory behind that was ejaculation can clear toxins and other substances that can cause inflammation. And so that's sort of the background behind that. Yep, next. And there are also medications that have been looked at specifically in clinical trials to look at prostate cancer prevention. The two medications that are studied are medications that are given for BPH, or benign prostate hyperplasia. And that's for oftentimes for, an overactive, more urinary symptoms that are more bothersome from an enlarged prostate. And those are the meds called Finasteride and Testosterone. And essentially what it showed in these studies, in the two trials, was that overall there was about a 25% reduction in prostate cancer. However, the ones who were diagnosed were more likely to be diagnosed with a higher grade cancer. And so because of this, the FDA didn't approve these meds for prostate cancer, but there are essentially meds that are basically getting evaluated at this point. Next. And so really the take-home point is overall diet, obviously aiming towards a healthy lifestyle, incorporating more fruits, vegetables, getting overall weight loss and regular exercise, and of course staying sexually active is all very, very important. Thank you, everybody.
Thank you, Dr. Jiang, for an excellent presentation. And I'll remind the audience that you have the ability to enter some questions in the Q&A part on Zoom. It's in the bottom, it says Q&A. So if you enter your questions, we'll be more than happy to answer the questions. And and go live with the speakers. After those two lectures, the first one and the next one that I'm going to introduce, you can enter your questions and we'll answer those. Our next speaker really needs no introduction. Dr. Ucho is fellowship trained in neurological oncology at the National Cancer Institute in Bethesda, Maryland. He was then on faculty at Yale University and was head of urology oncology at the VA there. He is currently the director of clinical trials at UCI Urology, and he has expertise in all areas of urological oncology, including prostate, renal, testes, and bladder cancer. Dr. Ucho is one of the leaders worldwide in diagnosis of prostate cancer through fusion biopsy, as well as advanced treatment of prostate cancer through focal therapy. And today, Dr. Ucho will be talking to us about prostate cancer, diagnosis, and genomics. Thank you, Dr. Ucho, for agreeing to participate today.
Thank you. Good evening, everyone. Next slide, please. I'm going to talk about prostate cancer diagnoses. We all know prostate cancer is very common. It's the most frequently diagnosed solid tumor in men. 1 in 6 men will be diagnosed with prostate cancer within their lifetime in the US. And over 238,000 cases will be diagnosed in the following year. Not only is it common, but it's also lethal. It's the second leading cause of cancer deaths in men. Close to 30,000 patients will die of this disease in the US. And what we know is when we detect prostate cancer early, when it's localized, survival is excellent. But when it's outside the prostate, it's advanced and metastatic, we have very poor survival. Next slide. So how do we diagnose prostate cancer? Well, we do a prostate biopsy. It's really the only definitive way to confirm prostate cancer. It's typically performed when patients have an elevated prostate-specific antigen blood test, or PSA, or an abnormal digital exam. We perform about 1 million of these biopsies a year in the US, and 3/4 of them come back negative using the current clinical standard. Next slide. So what is the current clinical standard? It's a transrectal ultrasound prostate biopsy. As you can see on the 2 left panels, that we can actually see the prostate with the ultrasound and direct the needle in different areas, such as the pattern shown on the right. Now, ultrasound isn't that sensitive that it actually can detect prostate cancer. We really use it for just placing the needles in different areas of the prostate. Next slide. So by all modern standards, this is really a blind technique. Next slide. So we do things a little differently at UCI as well as other institutions. We actually look for the prostate cancer and we try to make a map. We use magnetic resonance imaging, or MRI, and we actually look for the prostate cancer. As you can see in the top 2 boxes, the prostate cancer is in the right lower quadrant, a darker area. There's different sequences we can look at, like the right side on the upper portion, which actually shows density or diffusion weighted images, because prostate cancer is more dense, it's more thick, and that makes sense. In the lower 2 panels, prostate cancer also takes up much more blood flow, and that shows that we have enhancement or more blood flow to the tumor in that same location as shown there by the arrow. Next slide. So now if we can actually see the prostate cancer shown in the left upper corner where you can see the red marks, you can actually see the cancer on MRI. Now we can actually direct a needle within that cancer using a robotic arm. And at UCI, we use the Artemis 3T MRI fusion device as shown there in the middle. And under 3D, you can actually place that needle directly into the cancer. Next slide. So there's various ways you can approach the prostate and the way you can actually biopsy. The standard way is what we call transrectal. Actually, we go through the rectum or the intestine into the prostate to biopsy. As you can imagine, the infection rates are a little higher because of that technique. At UCI, we can also do what we call transperineal 3D MRI fusion biopsies, in which we go through the skin and thus eliminating the risk of infection. And that's really important in patients who have a very poor immune system or what we call immune suppressed. Next slide. So what does this mean? What does MRI fusion biopsy mean to the patient? It means a better biopsy. As you can see in the top two squares in A and B, you can actually see the lesion, see the cancer on MRI. And on C, D, and E boxes, we can actually place the needle with robotic arm directly into that cancer. And this equates to more accurate pathology as shown in F. Next slide. So what happens with that patient that we can't do an MRI? The patient has metal in his body, the patient has a pacemaker, maybe not MRI compliant. Well, now we actually use high resolution micro ultrasound. Now this ultrasound has a 300% improvement in resolution compared to that ultrasound I showed you earlier. The resolution is down to 70 microns and the image quality and detail is close to that of an MRI. So as you can see in the lower picture there, you can actually see the cancer surrounded by those red arrows and actually place the needle there and biopsy the patient without actually the help of an MRI. Next slide. So now that we can actually localize the tumor next, as you can see in this picture, you can actually see the MRI, you can see the cancer within the MRI, you can see the prostate. The biopsies in red show that there's cancer there. The remaining prostate, actually, the biopsy cores in green are negative. So the tumor is very focused. Next slide, next. And because we can actually locate the lesion within the prostate, we can actually just treat the cancer, leaving the rest of the prostate, thus having less side effects. And you can do this via different modalities. At UCI, we often do a high intensity focused ultrasound or HIFU. We have the Focal One device, which is the most contemporary unit available currently, which is a robotic HIFU device. And we were the first to treat in the United States. Next slide. So we all know prostate cancer is slow, right? And that all of them don't need to be treated because some of the patients never actually die of their disease. So how do we decide that? We look under a microscope, we look at their pathology, and we can put them in risk categories as shown on the upper row there. Next. But we can also do what we call tissue genomics, where we can actually reclassify these patients in the different categories. And what we find is half of them actually will reclassify. Patients who we thought were low or very low, next, actually can classify more in the intermediate risk, which we would actually treat. Patients that we usually would treat in the intermediate risk may classify in the lower risk, next. And thus, actually, we didn't need to treat them and we could have actually followed their cancer because it was never going to kill the patient, okay? So these tissue genomics give us a very personalized risk assessment. Next slide. So the evolution of prostate cancer treatment is changing. Next, we used to take out prostate cancer through a not so large incision, but an incision from a belly button down, and we used to take out their prostate and cure them. Next, with the advent of robotics, now we could do this through little holes. Next, but using tissue genomics, we can actually decide which patients actually don't need treatment. In addition, other patients that have very localized non-aggressive cancers, we can treat focally with focal therapy, as I showed earlier, in which they would have no incision at all. Thank you for your attention.
Thank you, Dr. Ucher, for a wonderful presentation. Very informative indeed. We have a few questions here in the Q&A part. Dr. Jiang, the first question is for you. What is the role of red meat consumption and prostate cancer, and whether adhering to a more vegetable-based or vegetarian diet is helpful to prevent prostate cancer?
That's a great question. Yeah. So there have been some epidemiologic studies that had shown a correlation between red meat intake and prostate cancer. A lot of it, though, is at least highlighting that, at least in the PLCO trial, they didn't show that there was not necessarily either amount or type of the meat that was associated with prostate cancer risk. However, those who had consumed a lot of well-done meat did have a higher risk of prostate cancer. So, I think as with anything, really moderation is the key, and obviously really avoiding those well-done and well-cooked or overcooked meats.
Great. Second question for you, Dr. Jiang, is if I had a family history of prostate cancer, what steps other than medication should I take to prevent getting cancer myself?
Yeah, so that's a great question. For those who are at risk for prostate cancer, or those, especially what really defines at risk is those who have a first degree relative, father or brother, who essentially is diagnosed with prostate cancer at an early age. And early age really we're defining as less than or earlier than age 65. And so those men, as well as obviously if you're of African American descent, really would be at higher risk. And essentially, when you're at higher risk, you want to start thinking about screening at an earlier age. So most men, we typically say at 50. However, for those who have high risk or very high risk, to start at potentially age 45 and 40. And these are really just discussions that you want to have with your primary care physician as well as potentially a urologist.
Thank you. Dr. Ucho, who would you recommend tissue genomics on? Would you recommend it on any man coming in for prostate cancer screening? How do you decide who needs to get that tested?
That's an excellent question. I think it really depends on the patient, and I'm sure that's what you're actually asking. We do a lot of clinical protocols here and study these genomics and the various companies that actually offer this. So we do check genomics on a high proportion under protocol. But I think if you look at the standard patient, a patient that's on the fence of treating, it's very helpful. Some of these genomics have some benefit in showing that they have a higher risk of salvage therapies post-standard treatment. And those may be helpful in patients who are trying to avoid side effects, as we all know that as patients get to multiple treatments or multiple therapies, their side effect profile does get worse. So there actually, I think there's an indication in many different facets. It really depends on the patient and what you offer. I think that the tissue genomics really is helpful when you offer all modalities like we do at UCI, as the whole spectrum from active surveillance all the way to focal therapies with minimally invasive therapies to full therapy, such as surgery and radiation. And lastly, we have high risk protocols that genomics will clue us into that we will treat with multimodality.
Along the same lines, Dr. Ucho, in whom you are one of the leaders across the nation and have done clinical trials on HIFU, and would you care to clarify to us which patients would you recommend HIFU to? What kind of prostate cancers do you think are the best candidates for this modality?
I think it really, again, depends on the patient. I think the ideal patient is, a quarter of the patients with prostate cancer will have unilateral disease. So patients that have disease confined to one side of their prostate, it's intermediate low risk patients, I think is the safest group to use. You can do HIFU whole gland. We've done trials with that. We've done it in the salvage setting in which it is effective. But I think because the data is limited, we make sure we counsel our patients regarding all options, regarding the limitations in data. At least most patients that get referred to us and we actually agree to treat usually are very focused unilateral disease, low intermediate disease. And majority of these low intermediates probably actually need no treatment at all. And I usually tell them that, but some patients actually insist on treatment. And I think doing a treatment that has side effect profiles almost the same as active surveillance is not a bad option.
Thank you very much, Dr. Ucho and Dr. Jiang, on your excellent presentations and answers to questions. Next, we'll go to Matt and Tim.
Okay, good evening, everybody. We get to be have a fun part of the evening tonight. I want to, before we start our drawing of incredible prizes, I want to again thank Liz Najam, not only for her sponsorship of tonight's event, but for so kindly and creatively making up 9 different gift baskets by hand, which we will raffle off throughout the evening. So I'll go ahead and draw the first name here as Tim grabs the first basket. And our first winner of the evening is Deborah Morrison. Deborah Morrison, congratulations. Excellent. I will put it back in the fishbowl. We don't want to give Deborah another one. Okay, lucky winner number 2 is John Kumas. I'm not sure if I'm pronouncing that right, but John, congratulations on gift basket number 2. It looks like it's a dessert theme with some pretty good looking stuff in there.
I'm jealous, looks really good.
Oh. Can you bring that over here? Wow,
Yeah.
that's a big one.
It's heavy.
And winner number 3 goes to Robert Mckay. Robert, congratulations. Another great gift basket from Liz Najam. Looks like a breakfast pack with, oh, it's heavy because there's an omelet maker in there. Good for you, Robert. Thank you. Dr. Yaffe, back to you.
All right, wonderful. Thanks again to Mrs. Liz Najm. She always surprises us with the most wonderful gifts, and thanks to Matt and Tim for giving away those gifts. Next up is also another person who needs no introduction, Dr. Thomas Allering. Dr. Allering is formerly the chief of the Division of Urology here at UCI, who was also previously the chief of the Division of Urologic Oncology. He completed his residency in urology at the University of Southern California, and he also completed a 2-year fellowship in urologic oncology under Dr. Donald Skinner, one of the pioneers in the field. He has received local, national, and international recognition for his expertise in urologic oncology, particularly in the treatment of prostate cancer using the robot, which is also known as the Da Vinci robot. He has actually performed more than 2,000 robotic surgeries, including the first robotic prostatectomy in Southern California, the first one in Denmark, the first one in Australia, and then the first one in my hometown in Canada. On that note, Dr. Allering will be talking to us about robotic prostatectomy.
Thank you. So I'm going to just briefly go over actually what a radical prostatectomy using the robotic approach is and show you some of the ideas behind why we do the surgery and how the implications of the robotic technique have dramatically changed. Next. The most important thing about robotic prostatectomy is we want to remove the prostate because it's an incubator. Basically what it's doing is it's driving the cancers to get more aggressive from grade group 1 up to grade group 5, which is the most aggressive. Number 2, next, is that the importance of the surgery is to not injure them. It's really critically important to have patients get through the surgery quickly and recover quickly. Number 3 is we want to preserve continence and sexual function. Next. So here's a drawing of the general scheme. To the left would be the upper abdomen. You can see the bladder there. Then the prostate attaches to the bladder as indicated. You can see the nerve with number 2 coursing along the right side and opposite on the other side. And then the other really critical, important area is the urinary sphincter is drawn there. And what we'll do is we'll remove the entire prostate and then hook that bladder down to the urethra. And so I'm going to actually just run through a video of this so you get a pretty good idea. So next. So this is clips taken from our surgery. So in this situation, we're on the prostate here. The feet are to the up. The head is towards the bottom of the screen. And we're cutting through that major vein that used to be a major issue. We use a lot of irrigation, one, to keep the temperature down and also to help view it. Now, this is what we call the apex, and this is where the sphincter is, and where that drawing showed the tight sphincter at what's called the apex, which is closer to the pubic bone. The pubic bone is just about an inch or 2 from here. And as you can see, we're generally just working our way slowly through. This is what we call the external sphincter. And then also to the right there, you can see that is the neurovascular bundle that extends from the upper left-hand part of the picture down to the right lower corner. And then you can see we're going to rotate the prostate to the left-hand side, and you can see the left nerve on the left-hand side there as well. And you can also just see that we're deep down underneath the pubic bone. The robot really limits the amount of bleeding and makes everything really much easier to see. And this is the most important part, the sphincter, the membranous urethra, which gives the sensation. And we learned just how important that is. And so, this is a little bit of an older video, and you'll see right here at the end that I cut and leave a little bit more tissue on the prostate than I would do now. We would take all of that tissue and leave it on the prostate in order to improve continence. But it really has made a major difference and helped for the recovery to be much quicker. Next. Now that the prostate's out, we have to get the bladder and the urethra back together. And again, a little bit more on the anatomy here. So next, you can see this arrow kind of points to where the external sphincter was, and I was showing you with the drawing. The legs would be to the bottom now, the head would be to the top, and you can see the bladder there. Next. The bladder neck is where we have autonomic control, and it mainly controls nighttime control. Nighttime control after a radical prostatectomy comes back in essentially 100% of the cases immediately, the first night that their catheter is out. And then we also have some issues with the bladder. Next. That can cause a little bit of frequency and urgency, or if the bladder is perfectly normal, then, I tell the patients they're going to pee like a 10-year-old. So we'll go through the reconstruction, which is where the robot has really made a huge difference. And we will see just how well you can see and how you can do suturing. So next. So again, the feet is to the top, and this major vein here used to bleed, 1 liter or 2 liters of blood at times if it was out of control. But with the robot and with the pneumoperitoneum, there's essentially no bleeding, and you can see that you can really get that part of the operation done without any issues. We have minimal bleeding, about 50 to 75 cc's of blood loss throughout the course of an operation. Now I'm oversewing the blood supply to the prostate so that we make sure that doesn't bleed. The next step is a step where we bring the bladder down towards the urethra to set up the actual connection of the bladder to the urethra. So you can just watch us suture these different structures to really just bring the bladder right down and take the pressure off the anastomosis so that the healing is much quicker and without problems. We used to have a lot of trouble with the scarring between the bladder and the urethra, and we have not seen one of those now in more than 1,000 cases. And so here we have, this is the connection of the urethra to the bladder, and we're starting to work our way up the left-hand side. You can just see you can operate right-handed, left-handed with the robot. You can put the needle within 1 millimeter of where you want to place it. And here, you know, we're about about done with the left side. And then this is, we're just finishing the right side. And then the catheter goes in, and then the catheter stays for about a week. Next. So, you know, the critical thing is in over 2,000 cases, no operative deaths. When we did it open, we would expect a death somewhere between 1 in 500 to 1 in 1,000. We've had no transfusions during the course of the surgery. Next. We're able to discharge patients the same day. They'll come in the morning and we'll let them go home at 6 o'clock at night. If they're an afternoon case, then we will keep them overnight. The pain is about 3 out of 10, and we don't need to use narcotic pain medication. Next. Most guys are able to return to work in 7 to 10 days. The catheter is removed after about 7 days. And next. We see continence rates, you know, when they're under the age of 65, it's about 98, 99%, which means they get off the pads completely. And if they're in their 70s, we'll see 93 to 95%. Sexual function, assuming that they have normal sexual function before surgery, is recovered in 85% or higher, significantly higher if they're under the age of 60. We're more like 95%. Next. And then again, the last thing is to get it out and hopefully get patients so that they don't get a recurrence. But the recurrence rate overall, we're about ready to publish on our 2,000 patients. We've seen about 20% recurrence rate. Thank you.
Wonderful. Thank you, Dr. Allering, for a wonderful talk and a very thorough discussion about all the steps of robotic prostatectomy and why truly we're able to get such great outcomes. Again, use the Q&A function at the bottom of the screen if you want to have some questions directed to Dr. Allering or any of the other speakers, and I'll be more than happy to ask your questions. Next, this is the first time we've actually done this. In 5 years of doing a men's health event, we've invited someone who is not from UCI to give a talk at our men's health event. And this is a testament to Dr. Lee's incredible CV and his incredible accomplishments. And we're truly honored to have him here today as our guest from outside of UCI. Dr. Lee is Associate Professor of Urology and Director of Robotic Urology, Urologic Surgery at the University of Pennsylvania. He is one of the most experienced robotic prostatectomy surgeons in the world. He's performed more than 6,000 surgeries. And we look forward to listening to Dr. Lee, who will be talking to us about the management of prostate cancer recurrence. Again, thank you, Dr. Lee, for agreeing to give us a talk today.
Great. Oh, thanks so much, Dr. Yaffe and Dr. Landman, for this really kind invitation to come speak today. And I just also want to give many thanks to Dr. Tom Allering. I trained under Dr. Allering, and I've always kept up with the wonderful research that he's done, and it's really helped me with my technique over the years to improve my results. Next slide, please. And this is the picture of the prostate after it's out. So after we've done surgery, and I did 5 of these today from sunny Philadelphia, then we have a specimen that looks something like this. And next slide, please. I think a great resource to keep in mind for anybody who's going through this or any type of cancer is the NCCN Guidelines. So this is a resource that's on the internet. It's updated constantly by a group of prominent medical oncologists, surgeons, researchers for every organ system that's commonly treated in which people get cancer. It's an invaluable resource for both clinicians and patients to wade their way through all of the different treatment options out there. And I think this really applies to this topic of prostate cancer recurrence. You can keep up with the latest recommendations through the NCCN. Next slide, please. So how do we determine whether somebody has a recurrence? As Dr. Allering said, We usually see that about 20% of men after surgery will have a recurrence, although there is controversy about PSA screening as far as detecting prostate cancer. After treatment, PSA is a perfect test here in this situation. One thing to keep in mind though, after surgery or radiation, the bars for success are a little bit different. After surgery, the number should be undetectable. So less than 0.2 or less than 0.05. As long as you see the less than sign before the number, it means it's undetectable. It's a nice clean number. After radiation, there's something called the Astro criteria, which is usually used, which means there's 2 consecutive rises after you see the lowest value obtained after treatment. What are the options for men? Well, it depends on what the initial treatment was. If you have gotten surgery first, then radiation is an excellent backup option. If you've gotten radiation first, then typically hormone therapy, chemotherapy is the next step, but other treatments can be performed, such as surgery, and we'll talk about that in a little bit. Imaging isn't usually done on a regular basis until we see that the PSA has gone up. So again, PSA, very powerful test here. Next slide, please. Dr. Uccio mentioned genomic studies. This is a very kind of hot topic. It's becoming more widely used. The kind of underlying basis is measuring the RNA that comes from the cancer cell specifically, and then being able to relatively measure the levels can help us to determine which cancers are more aggressive and which are less aggressive, as Dr. Uccio nicely described. Imaging is another topic that we briefly mentioned. We don't use this on a routine basis, but once somebody's PSA has gone up, then we start looking to see where these recurrences might have happened. Prostate cancer has a predilection to go to bone, so a bone scan is usually performed. MRIs are a great tool for looking at local recurrence. And then the new test on the block these days is an Axemen scan, which is a PET CT scan, which is much more sensitive than an MRI or a bone scan. Next slide, please. Radiation therapy can be used again after surgery. There are different types of modalities, photon, proton, cyberknife, but underlying, they're all very much the same concept. The course is still usually about 7 to 8 weeks. Hormonal therapy is usually used in conjunction. One of the positive aspects is that it is very effective. There's a high cure rate for men who get radiation after surgery with a minimum of early side effects, but there are longer term side effects. And so we do try to avoid radiation therapy if possible, but when it's necessary, it's a great tool. Next slide, please. Dr. Allering showed some wonderful video of his cases. For primary treatment, when the surgery option is used, robot prostatectomy is 90% of cases done in the US now, but in the salvage setting, after radiation has been performed, it's probably a secondary type of treatment. There are a lot of risks that are involved for surgery done after radiation. The primary one, which is a really big quality of life issue, is permanent incontinence. So older men who have a recurrence after radiation therapy, we won't usually recommend surgery. For some younger men who've gotten radiation at a very early age for some reason, then we will still offer surgery done, but guys have to understand that this is potentially a procedure with a lot of side effects. So then for older men, if we find that there actually is a case where everything looks confined to the organ after radiation and there's a recurrence detected, then cryosurgery can be used, which involves placing probes into the prostate, which circulate liquid argon, which can then freeze the prostate. Dr. Uccio mentioned the use of HIFU in these cases and HD brachytherapy, so temporary high dose radiation directly implanted temporarily into the prostate is another kind of up and coming treatment modality. Next slide, please. Next slide, please. So the mainstay for treatment for men who've failed the backup treatment would be ADT, or androgen deprivation therapy. So this involves getting rid of testosterone in men's bodies who are in this situation. Prostate cancer cells require testosterone for growth. Removal of the testosterone source, either through surgery or medications, can cause the cancer to regress. LH-RH agonists, or Lupron, this is one of two main types of medication used in this situation. These agonists cause the body to stop producing testosterone. Anti-androgens are another medication in the other class, which block the testosterone receptor. Once men get to this point, unfortunately, though, they are no longer in what we consider the curable state, but men can live usually several years on these medications, but there are side effects that are similar to what women go through with menopause. Next slide, please. Chemotherapy options are sometimes used in conjunction with hormonal therapy. There have been a bunch of new medications that have come out in the past 5 or 6 years. This is where we usually get our medical oncology colleagues involved. There's ongoing research as to timing, where to use these under what indications, and even neoadjuvant use in conjunction with surgery for high-risk men. Next slide, please. Thank you for your attention. Again, it's been a great pleasure and honor to speak today, and looking forward to the question and answer session.
All right, wonderful. Thank you, Dr. Lee. Thank you, Dr. Allering, for two wonderful lectures. Someone replaced the Q&A, Dr. Allering, with just a compliment. Someone wanted just to tell you that you saved their life. So I'm not going to name a name, but you can look in the Q&A. All right. Someone else is asking, why is there, this is a question for Dr. Allering, why is there a 20% recurrence rate after prostatectomy?
That's an excellent question, because the cancer cells were outside of the prostate before we got there. And, that's the biggest issue. That's why getting your PSA on an annual basis is really something that's important. There's been a drop off in that, and we've seen increased progression of disease, or coming in at a more advanced state, and we're seeing a bit more on the recurrence rate. So PSA is the way to do it, and then you have to go through the evaluation, and then you fall into Dr. Ucho's hands, and they can really do an excellent job of finding who has the cancer and who needs treatment.
Wonderful. And there's a compliment for Dr. Lee as well. So again, the Q&A is being used for complimenting people, not for questions. And it says, someone wanted to say hi to Dr. Lee, and your fellowship was a long time ago, but you are not forgotten. And it's from Dr. Deborah Morrison from Anesthesia. So I actually have a question for Dr. Lee. And the question is, I know Dr. Allering's biggest pet peeve is probably radiation therapy after prostate cancer surgery. What are your thoughts on that? Obviously, that's a 30-minute talk, but in a nutshell.
Tom is, he has a lot of really good points about this subject, but I think the world hasn't come around quite yet, and I think we need to hear more about the work that Tom's been doing. But yeah, no, across the country, it's still very standard therapy for men after prostate cancer surgery. If their PSA starts going up, that they're referred for radiation therapy. And so, yeah, this is one of the biggest drivers of radiation services in any kind of academic center or radiation center, because there are so many men who have prostate cancer and get it as their primary treatment or after surgery. And yeah, no, I think it's controversial, and Tom's making a lot of good points here. But, you know, I think one of the good things that we've seen is PSAs do go down. Many men then live really healthy, good lives, free from prostate cancer and PSA recurrence with the help of radiation. And fortunately, very few side effects. We've seen many of the guys come back, and I follow these guys for many years afterwards. And if they're treated at a high volume place, the side effect profile of men getting radiation therapy after surgery is really, really good.
We won't let Dr. Allering respond, because then we'll be here till midnight. But we'll have one more question here, and either one of you two can take it, because I definitely don't know the answer to this one. Is, do checkpoint inhibitors have any beneficial effect on recurrent disease? Either one of you guys can take it, or you know, you can bounce it off each other.
Well, I'll let David, because I mean, he was talking a bit on that, and it was in one of his slides.
I don't know that we have a clear answer on that yet. I think early work is suggestive that in the right patient, that it could be really useful, but yeah, you know, that it requires a lot of kind of further testing on the patient's part. And so this is, I think it's the future, you know, personalized cancer therapy for men after prostate cancer is, I think, going to be a big buzzword in the future, like it is for breast cancer in women already. You know, depending on hormone status, women's chemotherapy regimens are different based on those test results. And I think we're going to see more of that in prostate cancer as time goes on.
Well, I want to thank both of you. This is obviously a session that can, you know, bring on hundreds and hundreds of questions. Again, if anybody from the audience has questions that are left unanswered, or they think of questions later on, just write the questions down and we'll send them to the speakers, and we'll make sure they send you answers. And on that note, we're going to go back to Matt and Tim and for some more baskets.
Hello again, everybody. I still have my fishbowl, and Tim's got a new basket. So we'll do drawing number 4 for the evening. Again, thank you to Liz Najam for her preparation of these baskets. And the winner of the 4th basket here, which looks like a tea-related theme, is Maynard Kharkiv. Congratulations, Mr. Kharkiv. Now for the 5th basket of the evening. What do we have in there, Tim?
Looks like we got some brownie cheesecake, soup mix, and beer bread mix.
Oh, perfect. Okay, good combination. And the winner of basket number 5 goes to William Klein. William Klein, congratulations. And now for number 6. That looks like maybe game night, fitting a basket in the midst of our pandemic. And winner number 6 goes to Alexander Korn. Dr. Korn, congratulations. Back to you, Dr. Landman.
So I couldn't let Dr. Yaffe introduce himself. So I do have to admit, while Dr. David Lee is in fact a world-class expert and came to us all the way from the University of Pennsylvania, there may have been a titch of nepotism, and many of you may have noticed a family resemblance, even though I'm wearing this mask. He is my little brother, at least in spirit. Next, I have the great privilege of introducing Dr. Faisal Yaffe. So many of you may not realize that men's health is actually a brand new field. It's only been around a few years. And a few years before that, I was at a very fancy medical meeting, and I spoke to a guy named Wayne Hellstrom, who was probably the founding father or among the founding fathers of men's health. And I had just become a chair, and I didn't know anything about men's health. And he said that I needed to hire this guy who was his fellow. And I told him that I really didn't need this guy. No, and he insisted that I need to hire him. And in fact, it's one of the best things I ever did. So Dr. Yaffe is our men's health director. He's an assistant professor of urology on the cusp of associate professor, which should happen in the near future. Dr. Yaffe is a world-class expert in all things men's health. He's the director of our Birch Street Men's Health Facility, and truly not only one of the actual world's leaders in men's health. He does everything from research to teaching to great patient care, and we are just delighted to have him on our faculty. Faisal, please come on up.
All right. Good to go. Thank you, Dr. Landman, for the introduction. And actually, I wouldn't have minded introducing myself. I probably made it even better. But on, on that note, I'll be talking about sexual function after prostate cancer treatment. So next slide. So there are various issues that can occur after prostate cancer treatment. Erectile dysfunction is one. Ejaculatory orgasmic dysfunction is one. Climacturia, which is one people don't know much about it, which is leakage of urine with an orgasm, is another common one that can occur in up to 20% of people. Penile shortening is a really common complaint of men after prostate cancer surgery. And Peyronie's disease, or the development of a new curvature in the penis or deformity in the penis. Now, I could, as you can tell, I'm very passionate about these things and I can talk for an hour, but for the purpose of this topic, next slide, I'm gonna just talk about erectile dysfunction today, as you can see highlighted in red. So how do erections work? As you can see on the top, that's a flaccid penis. And on the bottom, it's a rigid penis. Now, can you press again, please? Here in red are the arteries. So the middle compartment that you see, those two big juicy spots that are filling up with blood, these are the arteries. Next, yeah. And what you see here on the periphery are the veins. So the way an erection works is the blood goes in through the arteries, through those middle channels. The penis expands and gets rigid, as you can see in the bottom, and then the veins, which are on the periphery of the penis, get trapped against the wall of the penis and can't get the blood back out. And that's how you get blood in, and the blood stays into the penis when you get an erection. Next slide. So what are the data about ED after prostate cancer treatment? So what you can see on the left, the vertical line, is the erectile ability, or the strength of the erection. And what you can see on the bottom is time. Can you click, please? You can see here, this is the period of time that is looked into this graph. And now next click, and next click. Those two first clicks show you after radiation therapy what happens to the erections. Like, you can see there's a very minimal drop in the erections, and they're pretty much stabilized over 3 years. Next click. This is what happens if you do prostate cancer surgery and you do not spare the nerves. Dr. Allering spent a lot of time talking about nerve sparing. Dr. Lee, Dr. Ucha all take great care about sparing the nerves. If you don't spare them, as you can see, the erections go down and they stay down and they stay inferior to the kind of erections you get with radiation therapy. Next click. And this is what happens when you do prostate cancer surgery, but you spare the nerves. As you can see, the erections will go back and they will be very similar at 3 years to what happens with radiation therapy. Thus the importance of sparing nerves. Next slide. So what are the causes of ED after radiation therapy? They can be because of damage to the nerves, they can be because of damage to blood vessels, and they can be because of damage to muscle tissue in the penis. Next slide. So when we talk about causes of ED after prostatectomy, it can be because of injury to the nerves. It can be related to the age of the patient at the time of the surgery. It can be related to any vascular risk factors. If the patient already has heart disease, peripheral vascular disease, that is going to increase the risk. If there's injury to the vascular system during surgery, that's going to increase the risk. Next click. Next. This will lead to structural changes within the penis. Next. This will lead to cavernosal failure and venous leakage, which we'll discuss. Next. And this eventually leads, the longer it persists, to the greatest risk of permanent loss of erection. Next. So why is it so important, and why are nerves so relevant to prostate cancer surgery? On the left is a picture, as you can see, a cartoon. On the right is an MRI of the prostate. Next. What's highlighted in blue here is the prostate. Next. These are the nerves. So as you can see, the nerves are really adherent to the prostate. So it's very easy to damage the nerves with prostate cancer surgery. That's where the robotic surgery comes in and allows really nice dissection of these nerves. And in good hands, like all the speakers that you've heard today, we're able to preserve those nerves. Next. So what are the predictors of recovery of erectile function after prostatectomy? The preoperative potency status. Now, if you didn't have good erections before surgery, it's unlikely that you're going to have good erections after surgery. The age of the patient, the younger you are at the time of the surgery, the better the odds of recovering erections. Whether the nerves were preserved or not. The time interval from surgery. So some data show 6 months is the earliest we look at recovery, but it can go up to 18 months. And some people will continue recovering erectile function up to 36 months after surgery. And finally, surgeon experience. As you saw today, we have speakers who've done thousands and thousands of robotic prostatectomies. Next slide. So can you help recovery? A little bit of issue here reading the slides because I'm a little bit far. So it can be because of temporary nerve damage, which leads to a decrease in nocturnal penile erections. This leads to lower nutritional oxygen status in the penis, eventually needs to replacement of the normal tissue, erectile tissue with fibrotic tissue, and eventually to decrease in erectile function and penile length. So next, you can stop this process with something called penile rehabilitation. And what is that? Next slide. If you look at the top, this is what we look at collagen fibers in the penis. And the left is at the beginning. And 2 months later, you can see that those white lines are much more significant. It means there's more collagen in the penis. The more collagen there is in the penis, the less likely the penis is able to stretch and the more scarred down the penis is. If you look at the bottom, on the left is initially, this is elastic fibers that allow the penis to expand. And you can see on the right, the elastic fibers disappear after 2 months. If there is no blood flow going to the penis, there's no blood flow, there's no oxygen. There's no oxygen, there's scarring. Next slide. So what are penile rehab options? You can do pills on demand. So you take a Viagra or a Cialis whenever you want to have sex, or you can take a Cialis or a Viagra every day to try to increase that blood flow into the penis. The data is controversial as to whether one of the two is better than the other. But what we can tell you is that most of us do believe that this does help recover erectile function. Next slide. You can do injection therapy. These are needles that are placed into the penis, into the side of the penis, and they allow the blood flow to increase in the penis and allows the man to get erection and recover some of their erectile function. Next. You can use vacuum erection devices, and some of you maybe recognize this from the Austin Powers movie. He calls it the Swedish pump. It's a device that's placed over the penis, and suction is used, and oxygen and blood flow goes into the penis. Next slide. So what do we do when we get a patient with post-prostatectomy ED? We bring them into this room like this one, and we do an ultrasound of the penis. I give them a small injection into the penis, then we measure blood flowing in and out of the penis, and I can tell them what's wrong with the penis. It's usually one of two things. Next. It can be that there is not enough blood flow going into the penis, which is basically a leaky faucet, a faucet that's just not giving you enough blood flow, enough water going into the sink, so the sink never fills up. Or next, it can be a problem that you are able to actually get water into the sink, but once it goes into the sink, it leaks out, which we call venous leakage. Or it can be both, or sometimes it can be neither, and it can be a psychological issue. And we are fortunate enough to have a sex therapist who works with us. Next. So what are the treatment options when you do have ED after prostatectomy? One option is to use pills. These include Viagra, Cialis, Levitra. They're all generic now. They're all very cheap. You can get them from compounding pharmacy. You can get them from your pharmacy using GoodRx at incredibly cheap prices. You can use injections into the penis when the pills don't work. We can use the aforementioned vacuum erection device. You can use these new gels or suppositories that you can put in through the tip of the penis, and they work like the injections, but without a needle. Or you can get surgery, what we call a penile implant, which is a device that we place inside the penis. It takes about 45 minutes. It has 2 cylinders in the penis, a pump between the testicles, and a balloon of water in the belly. It's all concealed in the body. And when a patient wants to have sex, he presses the pump. Water goes from the balloon in the belly, as you can see on the top, into the penis, and a man is able to get an erection and keep it for as long as he wants. Next slide. What about testosterone return of sexual function? There's a lot of controversy about testosterone, but what we know after prostate cancer surgery, if you look at the top 2 lines, the blue and the green one, these are patients with normal or high normal free testosterone levels after surgery. The red line are patients with poor testosterone levels, and you can see that the red line is significantly lower than the other lines. So if your testosterone is lower, you're less likely to recover your sexual function after prostate cancer surgery. Next slide. But this is blasphemy. We all know that testosterone is fuel to the fire for prostate cancer. If I give someone testosterone, they're going to develop prostate cancer. Next slide. Well, the number of articles showing that testosterone replacement causes prostate cancer is just as many as you can see in this box. There's actually no evidence whatsoever that testosterone causes prostate cancer. Next slide. What we actually know is that the prostate saturates or fills up with testosterone very quickly. So any additional testosterone that we give it, it doesn't care about it. So in that sense, giving testosterone to a man does not increase his risk of prostate cancer. But what we also know is that actually testosterone may actually reduce the recurrence of prostate cancer after radical prostatectomy. This is data Dr. Allering and I published and has been very heavily published and shown around the world, which shows that men who take testosterone therapy after prostate cancer have 50% less chance of recurring their cancer. And when they do recur, it's 1.5 years longer than other patients. Next slide. So in conclusion, ED may occur after prostate cancer treatment. Penile rehabilitation may help restore sexual function earlier. An objective workup of ED is recommended. Penile prosthesis surgery is an excellent option for men whose erections do not improve, and testosterone therapy is safe and may help restore erectile function earlier. Thank you for your attention. All right, let's go to the next slide here. You're still stuck with me here, and it's my absolute pleasure to introduce a friend of mine and a colleague. Be introducing Dr. Judy Choi. Dr. Judy Choi is the assistant professor within the Department of Urology. She's a urologist who's skilled in all areas of general and female urology with an emphasis on urinary incontinence. She obtained her medical degree with honors from Cornell University, and she completed her urology residency at Baylor College of Medicine in Houston, where she received the American Urogynecologic Society Resident Scholar Award. She then completed a fellowship in female pelvic medicine and reconstructive surgery at UCLA under Dr. Shlomo Raz. She has numerous awards, and we are incredibly honored and lucky to have Dr. Choi speaking with us today about urinary function after prostate cancer treatment.
Okay, thank you for that wonderful introduction, Dr. Yapi. So my name is Judy Choi, and I'm here to talk about urinary function after the treatment of prostate cancer. Next. So I'd like to briefly go over just some very basic lower urinary tract symptoms. So these include urinary frequency, both daytime and nighttime, urinary urgency, which is a sudden need to urinate, as well as incomplete emptying of the bladder. The one I'd like to focus on is urinary incontinence, which is the leakage of urine. And it needs to be subdivided into stress urinary incontinence, urgency incontinence, or mixed urinary incontinence when you have both stress and urgency incontinence. So stress urinary incontinence is the leakage of urine. Stay on that slide, please. Stress urinary incontinence is the leakage of urine with coughing or sneezing, and urgency incontinence is the leakage of urine that occurs when you don't make it to the restroom in a timely manner. Next. So the type of urinary incontinence after prostate cancer treatment can be related to the type of procedure you undergo. The size of your prostate prior to treatment and a history of urinary symptoms prior to treatment also play a big role. Next. Now, it's very important to differentiate the type of urinary incontinence you have because they have different treatment options. They have different mechanisms, different causes, so they have different treatment options. Stress incontinence, the leakage you have with coughing and sneezing, is more common after a prostate is removed in surgery, and it's related to the deficiency of the urinary sphincter. So the stress placed on the bladder overwhelms the strength of the urethra, that leads to leakage. In the next image, the urgency incontinence, that's related to basically an overactive bladder and bladder spasms. And it can develop more with a history of an enlarged prostate or after radiation treatment. Usually after a radiation treatment, if it develops, the effects may be temporary. And then the last picture on that slide, the overflow incontinence occurs when the bladder is blocked, say from an enlarged prostate, may occur after radiation treatment just because the prostate's in place. Next. So urgency urinary incontinence is related to the nerves and muscles of the bladder, and it has its own set of treatment options. Typically, we recommend behavioral modifications as a first-line option, such as regulating the total fluid intake that you drink in a day, cessation of bladder irritants like alcohol and caffeine, as well as changing the timing of fluid intake. So for instance, you stop drinking fluids 2 to 3 hours before bedtime so you don't wake up as often. Now, if those don't work, then we can recommend medications that relax the bladder. If none of these are successful, then we can discuss having procedures that decrease bladder spasms, such as PTNS, which is basically like acupuncture, Botox injections to the bladder to prevent spasms, and sacral nerve modulation, which regulates nerves to the bladder. Next. Stress urinary incontinence treatment options, and that's again, the leakage with coughing and sneezing, can be conservative and non-surgical. Non-invasive treatments usually are the first line in the management of early incontinence that follows a prostatectomy. So typically we don't recommend significant intervention in the first 6 to 12 months after a prostatectomy. That is, if you have urinary incontinence, if you are lucky enough to be a patient of Dr. Allering's, and a lot of members of our team, may not even be an issue. But if mild, we can recommend pelvic floor exercises such as Kegel exercises to strengthen the urethral sphincter and pelvic floor physical therapy, which involves a physical therapist trained in the pelvic floor, or other incontinence management options like incontinence pads or diapers, condom catheters, and even penile clamps. Next. For patients with more severe stress urinary incontinence, we can offer surgery, and that comes in two main forms: male slings and artificial urinary sphincters. Next. A male sling is basically a mesh sling that supports the urethra and its surrounding muscles. It's helpful in patients with mild to moderate urinary incontinence, and that definition of mild to moderate urinary incontinence, that varies. It's similar to the type of slings that are placed in females for stress incontinence, but it differs in the mechanism by which it actually provides continence. Next. So the way that the male sling works is it provides extra resistance to the urethra when you cough or sneeze by basically increasing the functional membranous urethral length. So you have more area in order to basically squeeze and provide that contraction that you want. Next. The benefits of the male sling are that you can urinate normally in your standard fashion. It can result in immediate continence, and it has a high cure rate. However, there's a risk of difficulty urinating, continued leakage, infection, and unique with the mesh, erosion of the mesh into the urethra, as well as subsequent pain. In these cases, the mesh can be removed or revised. Next. However, depending upon your definition of a success, and it varies based on the research article that you're reading, it can range from a success rate of 62 to 78%. Next. Now, a more aggressive approach for stress incontinence would be the artificial urinary sphincter. There are 3 components to the sphincter, so it's quite a complex device, and it basically hasn't changed its form since it was first founded. Around the urethra is a saline-filled cuff that compresses the urethra to keep it closed. In order to activate the device, there's a pump in the scrotum that you need to press in order to urinate. The third component is a reservoir in the lower abdomen, which holds the saline for the cuff and the pump. Now, artificial urinary sphincters, or AUSs, are considered the gold standard treatment for stress urinary incontinence after prostatectomy. Next. Go ahead and hit play. So here's a quick video showing the mechanism of the artificial urinary sphincter. So highlighted in yellow is the sphincter itself. And at baseline, the cuff is filled, compressing the urethra. You activate the pump in the scrotum to open the cuff surrounding the urethra so that urine can pass through. The saline is pumped from the cuff to the reservoir upon activation, and then it actually auto cycles back to the cuff after urination is completed. So at default, it's closed. Next. Okay, so the benefits of the AUS are that it can be used in men of all types of severity of urinary incontinence, anywhere from mild to severe, and it has a reported patient satisfaction rate of 90%. However, it does require good hand function, as you saw from the video. It requires a pretty complex 3-part device altering the mechanism by which you urinate. And additional risks include device malfunction or failure, erosion of the cuff along the urethra, continued leakage, infection, and pain. And again, these can also be removed if the complications are high. Next. So this is just a quick summary of urinary function after prostate cancer treatment. Thank you all for your time.
All right, wonderful. Thank you, Dr. Choi, for a wonderful review of urinary incontinence after prostate cancer surgery. I'm going to read a few questions here from the Q&A for myself and for Dr. Choi. The first question is is regarding ED is how early should penile rehabilitation be instituted after prostate cancer surgery? And the real answer to this is the earliest possible. If you looked at the slide where I showed some pathology and I showed what the tissues look like in terms of collagen and in terms of elastic tissues, you saw that it only takes 2 months for some scarring to occur in the penis and for some irreversible changes to start happening. So what I would suggest is every patient who's had prostate cancer surgery, check their testosterone levels. If needed, we can replace the testosterone levels. Now, again, there are some exceptions. We like to put everybody on a daily pill for their erections, whether it is a daily Cialis or a daily Viagra, and then give them pills on demand as needed. If for patients who are motivated, also we would recommend giving a vacuum pump, because that pump allows to stretch the penis also to prevent any kind of loss of length, but also may increase some of the tissue oxygenation. So these are steps that patients can use to be a little bit more proactive and can definitely help recover erections. I have a couple of questions for you, Dr. Choi. The first one is, how long would you wait before doing surgery on a patient with post-prostatectomy incontinence?
Yeah, so as I was saying, most people will wait a year, and that's our basic training. You know, you just want enough time to kind of develop those muscles, see where your baseline is, use those Kegel exercises, because you basically want to strengthen the pelvic floor as much as possible, see where your natural baseline is. You know, the sphincter it's a complex device, and it does change the way that you urinate. So, you know, if possible, we can take somebody from a more severe incontinence, have them work through either Kegel exercises, physical therapy, or what have you, and then downgrade down to a sling if needed.
Perfect. And the second question for you, Dr. Choi, is do medications play a role or help with incontinence at all after prostate cancer surgery, or are the treatments only Kegel exercises and surgery?
So it depends. So medications for urinary urgency incontinence. So that's, you know, with a feeling that you go very frequently, urgently, you don't make it to the restroom in time. You know, I wouldn't recommend surgery in that case. You recommend, you know, those behavioral modifications, medications, you know, more conservative therapies. So it really depends on the type of incontinence that you have. So for urgency incontinence, I would say medications. Now, there are some medications that have some effect to help with with the treatment of stress incontinence. But I would say the success rates of those tend to be pretty low when it comes to stress incontinence. And so we can trial that for patients who want to avoid surgery. A couple of people notice a little bit of benefit, but usually not substantial enough to give them a great continence, right?
Thank you, Dr. Choi, for answering the questions, and I appreciate you being here with us tonight. Before I hand it over to Matt and Tim for the third round of baskets, this is the last of me on the screen today. So I want to thank again all of you for participating and for being here today. I know it's late. I know a lot of you are probably unfortunately affected by the fires that are occurring, so our prayers are with you. But again, I would like to thank our old friends for coming again, for our new friends for coming. I hope you've learned something. I've definitely learned a lot today. And we hope to see you next year face-to-face for the 6th annual Men's Health Day. And on that note, I'll hand it over to Matt and Tim for number 7, 8, and 9 of the baskets. I hope I win, actually.
Okay, back by popular demand, Barker's Beauties for one more round of drawings. Here we have looks like a soup-related theme. Looks pretty good. I'm getting hungry. And our winner of basket number 7, another difficult name to pronounce, Mansour Kohanteb. Mansour Kohanteb, the winner of basket number 7. Basket number 8, we have Tim bringing it out now.
This is my favorite right here.
Tim's personal favorite.
Mm-hmm.
And Tim's personal favorite now belongs to Brian Mock. Brian Mock, congratulations. And last but not least, I think we saved the biggest basket for last. Lift with your legs, not with your back, Tim.
Yeah, really.
Looks like a pasta themed dish or basket. All kinds of good stuff in there. And this basket goes to Hazem Chahabi. Hazem Chahabi, you are the winner of basket number 9. Congratulations.
Thank you, gentlemen. And I love seeing Mr. Prelitz play the part of Vanna White tonight. So I think after this evening, and having met some of the faculty at the UCI Department of Urology, you can begin to understand why for me it's such a great privilege to be part of this faculty. I want to thank all the speakers, really brilliant and talented presentations this evening, quite outstanding. As you all know, this evening celebrates Men's Health, and particularly the memory of Dr. Wadi Najam. Wadi left us too early. He was truly ahead of his time, understanding the importance of prevention and men's health. And quite frankly, as I hear more about him and learn more about him over time, that was one of his major accomplishments. The other one was the utter passion that he engendered in his patients with just brilliant care, which I think all of us have to remember every day. We will continue to honor his memory every year, and want to thank him and his family for allowing us to do so. For those of you who enjoyed the evening and are interested in learning more about our Men's Health program or the Prostate Cancer Center, I'll encourage you to reach out to Mr. Matt Spencer or Tim Prelitz, the guys giving away baskets today. In just a moment, their contact information will be behind me. We remain grateful to the support that everyone, all of you in our community have provided us. And we look forward to partnering with you further. We really believe in upping our game every year. We were number 24 this year, and would be utterly surprised if we can't do better next year. So please, we're living in a very challenging time. From all of us here at Men's Health Central tonight in the Phoebus Landman Conference Room, thank you very much for your attention. We are so grateful. Stay safe from COVID, stay safe from the fires, and we look forward to seeing you next year, hopefully in person. Good night.